All right, go
All
ahead,
right.
Kayla.
All right. So I'm Kayla Robinson. I am the ICC Program Director for Community Healthlink, the Families and Communities Together program. So we're affiliated with UMass as Community Healthlink, but we also have Luck, who's another agency I'm sure you're all familiar with. They contract with us. So it used to actually be 3 agencies that all contracted together. It was Community Healthlink, Luck, and the Willis Center. And unfortunately, the Willis Center closed several years ago. So now it's just us and Luck that offer these services for this area specifically. So what exactly are we? So we're the contracted community service agency for this area. The way the state of Massachusetts works for children's services, each part of the state has a community service agency, which kind of lines up with the DCF area offices. So for example, we're the North Central CSA, there's the Worcester East CSA, the Worcester West CSA, South Central CSA, and we follow all of the DCF offices across the state. So Community Healthlink has 3 of those CSAs. It's North Central, Worcester East, and Worcester West. And our program is made up of intensive care coordinators and family partners. And we provide what we call wraparound services to families. That's an evidence-based practice. And I'm going to get into a whole lot of detail about that in a few minutes. But for now, we'll just kind of start with the basics. So our program was started in June of 2009 after a class action lawsuit against the state of Massachusetts that many people refer to as the Rosie D lawsuit. So what was the Rosie D lawsuit? It was a group of parents that got together in 2001, that's when their lawsuit started, on behalf of their children, saying that there weren't enough services in place, community-based services, to keep their children out of the hospital and in their homes. So in response to that, after many, many years of litigation, you'll see it was filed in 2001. Our services didn't actually start until 2009. The state of Massachusetts created the Children's Behavioral Health Initiative, CBHI services is what it's often most commonly referred to. And the focus is to give more community-based services to children so that they can stay in their homes and in their communities and not be constantly in the ER or in placements and residential placements. So what are CBHI services? It's a breakdown of several different services. Like I said, we cover intensive care coordination and family partners, or what's sometimes referred to as family support and training. It's a bunch of alphabet soup. So I often talk in acronyms. If at any point I'm saying something that you're like, wait a minute, what does that A, B, C, D, E mean? Feel free to stop me and jump in, but I try really hard when I'm doing these presentations to make sure that I'm using the full names versus the acronyms. So we're 2 pieces of CBHI services. There's also a service called in-home therapy. That service is meant to be in the home. It's a 2-person team. You have a clinician and a paraprofessional. They call it a therapeutic training and support staff, but it's a master's level person and a bachelor's level person. They work in a 2-person team. They typically offer about 7 hours a week of in-home services. So that's family therapy, one-on-one support to an identified client. Sometimes they do work with the parents, sometimes they do work with siblings. If there's a grandparent in the home, anybody that's in the home, they can engage in therapy if they're open to it. But it's to help stabilize that child in the home and prevent a need for an out-of-home placement.
Amy, do you mind, Kayla, excuse me, do you mind if I interrupt?
Sure.
I just want to ask, does it matter if children are in foster care? Can they receive these services?
Absolutely. So any child, these are primarily Mass Health funded services.
Right.
From 2009 to 2020, it was only Mass Health that would cover it. Recently, some commercial insurances are offering support, but any child that's in foster care automatically gets Mass Health through DCF and therefore is eligible for any of these services.
Okay.
DCF does need to consent, which sometimes can be a barrier getting in touch with the worker, unfortunately. But we try really hard if we feel like there's a need to get in touch with that worker, because we don't want that to be the barrier. We don't want that to be the reason that a kid that needs services isn't getting it.
Right. Great. Thank you.
Absolutely. So that's in-home therapy. There's also therapeutic mentoring. That's a bachelor level staff that goes one-on-one with a child into the community and does typically about 4 hours a week of community-based support with them. Their role is really skill building. They're not a clinician. they typically, they have to work under a clinician. So there has to either be an outpatient therapist, an in-home therapist, or an ICC, an intensive care coordinator involved, and they act as a hub for the therapeutic mentor. So because a therapeutic mentor is bachelor level, it's a clinical person over them to oversee and kind of guide them in the work that they should be doing with that child. But that's a service that's meant to be in the community, working on social skills, you know, getting them connected to the Boys and Girls Club, getting them connected to a basketball team, just helping them engage with peers out in the community. There's also in-home behavioral services. It's very similar to IHT, but slightly different. So in-home therapy is a therapeutic service. They're working on, you know, family therapy, the bonding between the siblings, the parent-child interactions and attachment. In-home behavioral is very strictly focused on behaviors. For anyone who's familiar with ABA services, it's pretty much following that model, just at a lower level because it's funded by Mass Health differently. So these are for kids that maybe aren't ready for the therapy. Maybe you've got a kid that is in foster care and they've been through a ton of trauma and they need therapy, but they're just not at a place that they can do that yet. Sometimes they'll refer for in-home behavioral, and the focus of in-home behavioral is just to look at those behaviors, create structure and plans, and teach parents how to respond to the behaviors and only focus on that. In very rare circumstances, you might have both an in-home behavioral team and an in-home therapy team, but they're both intensive services. So both of them are intended to be 6 to 7 hours a week in the home, which, as I'm sure you know, if you have kids in school, 6 to 7 hours a week after school is a lot of time. That's pretty much every day of the week dedicated to services. And then when you have 2 intensive services at the same time, it's just a big ask of a parent, and it's a lot of moving pieces. So often it's one or the other. If you try in-home therapy and that's not working because the kid's not really there yet or not really ready to work on the therapy piece yet, the clinical pieces, then they'll put in in-home behavioral instead. But it's pretty rare that we do both. And then the last piece of CPHI services is youth mobile crisis intervention. They work and support with children and families where there's a crisis situation. So you have a kid that's saying they're suicidal or they're homicidal or they're experiencing hallucinations or they're having an extreme tantrum that's lasting several hours and the family just doesn't know how to respond. Pre-COVID, they would go out to the home, and it's again a 2-person team, a clinician and either a bachelor level staff or a family partner, a parent who has lived experience raising a child with some behavioral health challenges. But the 2-person team would go out to the home, they would offer some support and stabilization, and they're really looking at, do they need connection to any of these other services to help maintain stability, or does the child potentially need a higher level of care? Since COVID, oh, sorry, go ahead.
No, go ahead.
I was going to say, since COVID, the teams aren't going out in person just for safety reasons, and with the volume of cases. I know our mobile crisis team, they're a part of Community Healthlink, and they've had, you know, sometimes 20 kids waiting for beds, which means they need to see each of those 20 kids every day until they're placed, in addition to incoming cases that come in day to day. So they haven't been able to resume going back out in person because just the volume is so high that they need that travel time that they save by doing telehealth to be able to accommodate everybody.
Awesome. The only thing I was going to say was our last training, which must have been in December or late November, we had 2 people from Youth Mobile Crisis that came and spoke, right? So they were, I want to say they were med students.
Yes.
With Diane Lanny was
Yes.
the from Faces, right? That gave the presentation. Okay.
Yeah, and they'll be joining us again in April and June to talk more about their services. So it's interesting to see how they tie together and how you guys work together. So thank you.
Thanks.
Yeah. And the goal of all of these services is to work together. It's in our specifications that when a family is seen by mobile crisis, we're in communication with mobile crisis, we're in communication with the IHT team. So the hope is that this whole team can come together to help stabilize that child to the point where they don't need a hospitalization. But if they do, then to have a really good plan for when they get discharged for how we're going to support the family. So I'm going to dive a little bit more into our service now, the ICC and the family partner, and what those roles are. So wraparound, which is the evidence-based practice that we use, really focuses on and highlights the importance of professional knowledge, but also experiential knowledge, that family partner piece. So professional knowledge comes from formal training and education and experience that you gain in professional roles. It's very scientific, right? When you're talking about evidence-based practices and being clinical and understanding attachment theory, that all comes from that professional knowledge. But we recognize the importance of that experiential knowledge. So coming from lived experience, what is it like to live in a family where you're raising a child with some behavioral health challenges? It's really easy for a provider to come in and say, oh, you need to do A, B, and C. The role of the family partner is really to ground us and saying, like, maybe A, B, and C is not realistic, and we're just going to do A for right now, because actually being in this is really difficult day to day. So we really look at both roles as equal and equally important to the family and offering them the support and stabilization that they need. So our role as care coordinators is to bring everybody to the table and have a conversation about what's going on to create a plan that's going to support the family. So we all have different missions and mandates, which often guarantees different points of view, right? So we have schools, and their focus is on educating the youth because that's their role on a team. We have DCF, and their focus is safety. So is there abuse or neglect or areas of concern there? The juvenile justice system, really focusing on the safety of the community. Is that child safe enough to be in the community? Or are they a danger? Mental health care, which focuses on the child and family's mental health. Medical care, that focused on the child and family's physical health. So each person kind of comes to the team with their point of view and what they think is important. Our role in care coordination is to bring all of those pieces together to see if we can come to a happy medium where we're meeting all of these needs and everybody's satisfied with the plan. Not everybody is always going to get the thing that they want out of it, but we hope to make it so that there's some harmony on the team. So we are not therapy. The intensive care coordinator and family partner are not there to go in and do direct clinical work with the child. Most of our work focuses with the parents, and it's a process to encourage collaboration and family voice. So part of wraparound is understanding that it needs to be based on the family's prioritized needs. Because when DCF comes in and says, what is important to them is the cleanliness of the home, and maybe for the parent, that's not a big deal. It's very difficult to make progress because we're focusing on what somebody else is saying important and not what that parent is saying is important. So we really focus on the family's voice in their team, and that it is the family's team, not anybody else's. So they're the decision maker at the end of the day. We put them at the center of the process. We use the support of the team of professionals. So we do what's called brainstorming in our team meetings, where we ask everybody to come up with different ideas. So it's not that we're saying professionals don't know what they're doing. We ask them to come and offer different ideas and suggestions, but ultimately it's the family's choice what they're going to work on and what they're not going to work on and how they're going to work on it. So the care coordinator, their job is to facilitate monthly team meetings. In between those team meetings and before that first team meeting, they're reaching out to everybody. So not only are they prepping the caregiver, but if you all are involved, they should be reaching out to you and asking you to come to the team meeting. If DCF, the school, in-home therapy, mobile crisis, whoever is involved in that child's life, the care coordinator is going to be the one that calls and has a conversation with them about what this process looks like. We're all going to come together. We're going to focus on what the family wants to do. You're there to offer suggestions, but we're not forcing the family to do anything. And then whatever's decided in that team meeting, maybe in-home therapy is not involved, but the team agrees that that would be helpful and the parent wants to do that, the care coordinator can help with making those referrals. As we move along in the process, we try to teach the family those skills so that when we close our services, if 6 months down the road they need in-home therapy, they know the resources and how to go about making those referrals. So oftentimes, if we've been involved for a while, maybe the care coordinator is not just going to jump in and make that referral, but they'll sit with the family and do it with the parent so that if the parent needed that service down the road, they'd be able to access it. The family partner has a different role. Unlike DCF, where they put in a parent aide, it's a different role. The parent aide is there to like teach a curriculum and work on their parenting skills. The family partner is there as somebody who has been in that parent's shoes and to help them navigate this difficult system, right? Like we all work in this system and it's still difficult to figure out and navigate what services are the right services and how to make referrals and all these pieces. So the family partner is there to support that parent along the way. They meet with the parent on a weekly basis, and they try to do some skill building with them. For example, let's say we have a parent that doesn't have transportation and their child has psychiatry and they need transportation to that. Our family partner might drive them once, but really the goal of the family partner is to find sustainable options for that parent. So they might, instead of just driving them to the appointment every week, they might teach them to ride the bus. They might teach them how to get like an app on their phone to do a ride share, like Lyft or one of those. But it's not sustainable if the family partner just drives them to the psychiatry appointment every week, because then the parent, when that family partner has to close their case, doesn't have the skills to be able to get their child to psychiatry. So it really is about skill building. In some cases, parents don't necessarily need the skill building, but they do need somebody to like hear them and understand where they're coming from. So sometimes our family partners are just like a sounding board for the parent. They've had a really tough day. The kid's just been a mess. They don't know who else they can call. They call the family partner and just like vent a little bit, and it's a safe person that they can vent to. We are all mandated reporters. So obviously if somebody said something that was really concerning, we would have to file a 51A on that, but we make that very clear to the parents from the beginning, and the family partners are really sensitive to that and really open and honest with the parents. So that's typically not a concern for us. Like I was saying, they help get the families connected to long-term resources. So we don't want to make the families dependent on us. We want to teach them the skills so that when we are ready to transition our case, they know how to access the supports that they need. So the wraparound process. So sometimes our collaterals get frustrated because once we get into place, they think, all right, you're here, make all these referrals. We do have a process, and again, it's based on an evidence-based practice, so it's really important that we follow it. So in the first phase of enrolling with a family, we work on engagement and team preparation, and that's typically about a month. So we'll meet with the family on a weekly basis, and we do a safety plan with them. We have them sign all the consents and releases, and then we do a really in-depth assessment of not only the child, but the family, because we don't want to make a referral for in-home therapy and then find out 3 weeks later or 2 months later that maybe in-home behavioral would have been the better service if we had dug a little bit deeper because they've already tried therapy 3 times. So we really try to get a thorough assessment done in that first month. We're also reaching out to the collaterals in that time to figure out what their work has been with the family, what they think would be supportive, and anything that they think would be important to this care planning process. Once we've gotten all of our information, we have that initial care plan. So that's our plan development. That's typically around the 4-week mark. Sometimes it can be a little bit longer, but insurance is pretty strict with us about the expectations there. So it's typically going to be around the 4-week mark, and we're going to create that first plan. So we're going to ask the family for what we call a vision. And the question that we often ask them is, if you had a magic wand and things were better for your child right now, what would that look like? And that's what we want to work towards. We don't always get there, but we try to take steps to get there. And then there's plan implementation. So typically that's somewhere around the 3 to 6 months and on mark where we then start implementing the plan. So that's going to be around the time where we start making referrals for people, because we want to make sure that the services that we're referring for are the right fit for that family, and that we're not just jumping to conclusions or jumping to a service where maybe instead of in-home therapy, the family could try like a family movie night once a week or something simple that they can do themselves without needing a formal service in place. So we try to look at all the options. And then once we feel like the family's in a good place in terms of their care coordination, so it doesn't mean the kid's going to be perfect and everything's going to be fine, but when the family feels like they've got a good team in place and things are going how they're supposed to and they're working with the right services, then we start to move towards the transition phase. We are paid by insurance, so we're bound by their guidelines for us, which means oftentimes we're involved with a family for maybe a year or 2. We are not a long-term service. We're meant to be intensive and short-term and get the right people in place. And then we work to transition out of the family's lives. And that can be difficult because people like having us around. It makes their lives a lot easier when we're kind of bringing everybody together and coordinating. But the goal is by the time we're transitioning, there's a plan for how that's going to continue if it's something that needs to continue. So how do kids qualify for our services? This is the big piece, right? So the first piece is there has to be what the insurance companies call a serious emotional disturbance. This can either be that the child has a mental health diagnosis or that they have symptoms of a diagnosis. So maybe the child hasn't been diagnosed with anything yet, but based on their behaviors, you're seeing that they're probably going to meet criteria for a diagnosis. And that could be anything from ADHD to depression to bipolar disorder. The only diagnosis that we have trouble with is autism. So if a client strictly has an autism diagnosis and there's nobody saying that they meet criteria for anything else, then our suggestion would be that they work with ABA services and DDS, the Department of Developmental Services. And the reason for that is insurance says that all of the stuff that we offer, the different clinical therapeutic services, that doesn't work for kids on the autism spectrum based on research. They respond best to ABA. But typically, I will say most kids that have an autism diagnosis often do meet criteria for something else because it's just not that black and white. So depending on the kid and what's going on, there are times that we will make exceptions to that rule. In addition to the diagnosis or the serious emotional disturbance, I hate that language, but that's the insurance's language. There also has to be functional impairment. So the child has to be struggling in an area, either at home, at school, or in the community, or a combination of those three areas. So sometimes you get a kid that's diagnosed with ADHD and they're doing great in all of those areas. They wouldn't need our services. This is really for kids that are really struggling to be safe in the community. And in addition to those two criteria, there also has to be a need for multiple services or multiple services currently involved, right? We're there to coordinate care. So maybe there is for example, we have a case right now, the child's really struggling, but the parents don't want any services in place. So in that case, our hands are tied. Our role is to coordinate care. And if there's nobody giving care, there's nothing for us to coordinate. So that also is a big piece. How to make a referral. So an important piece is talking to the family about our services before making the referral. Our services are voluntary and families have to consent to working with us because if the parents are invested, we work primarily with the parents. We're not going to be able to make a lot of headway. I know oftentimes you guys work with cases where there are funky custody situations, maybe DCF has custody and there's a foster parent and a bio parent. You know, in those situations, it's going to depend on, are we reunifying? Is the kid on the adoption track? If we are reunifying, how close are we to that? You know, maybe foster parents and DCF are on board, but bio parents really want nothing to do with us. If we're working towards reunification, that might not work out. We could get started, but then once they go home, if the parents aren't buying into our service, that's not going to be a successful service for them. And there are other kind of difficult situations we get into. The important part is that the legal guardian has to consent, but then the person who's actually caring for the child day to day has to be invested in our services. So I have a referral form that I will send over to Jamie that you guys can use if you have families that you want to refer to us. You just have to make sure all the sections are complete. The reason for referral explains the need for care coordination. So are there a lot of services in place? Do you feel like the child needs a lot of services? Sometimes we help out with like a kid that's trying to get on an IEP at school and the parents don't know how to navigate that process, or a child that maybe needs neuropsych testing. That's really helpful for us to know in that initial referral, because once we get a referral, we initially outreach to the person who has legal guardianship or legal custody. And that person consents. And then if the caregiver is somebody different, we're going to reach out to the caregiver. And sometimes in these cases where DCF has custody, a DCF worker is going to consent because they're going to want the right service for their kid. But then when we call the foster parent, They're like, well, who are you and what do you do? And I already have 5 other therapists. So what are you guys going to do that's different? So it's helpful for us when we can say, oh, well, Lynn said you really needed help with the IEP process, or Lynn said you're having a hard time navigating and getting everybody to communicate with each other. Whereas if we're just, oh, well, there's stuff going on for your kid, they don't really understand the need for our service. So families can also access Family Partner as a standalone service. So sometimes there's not necessarily that need for the care coordinator, but there is a need for the parent to have that support of a Family Partner to have somebody help them navigate the system. We can accept those referrals, but they are hub dependent, which means just like the therapeutic mentoring service, where they need an outpatient therapist or an in-home therapist, for Family Partners, it's the same, because their only requirement for the job is that they have lived experience. So they're not clinical, and oftentimes they're dealing with really difficult cases. So the expectation is that there's either an outpatient therapist or an in-home therapist, and then you guys would have a conversation with that person and they would have to make the referral. Because in addition to filling out the referral form, they have to get us some additional documentation, just so the Family Partner knows all the clinical information that they need to know about that child. How to find services. So there's this great website that I shared with Jamie. I don't know if she shared it with you guys yet. I'm going to do a screen share to get to it so you guys can see it. So it's mabhaccess.com. And again, I'll send this to Jamie so she can share with you guys. So it's this wonderful website. It has a section for youth and family. It also has one on substance use disorder and mental health, but this is probably the section you're going to go to most often. So if you click on youth and family, it has a description of each service. So it explains to you what's mobile crisis, what's intensive care coordination, what's in-home therapy. And then you can click on this find openings option, and you pick what you're looking for. So if you're looking for in-home therapy, and it's, let's say, for an 8-year-old, and I'm going to go with Worcester just because that zip code comes easiest to me. You click search, and this tells you every single agency that covers Worcester, the number of openings that they have. So for example, Arbor Counseling Services right now has 8 openings for in-home therapy services. It has a referral phone number, has some comments. So especially right now with COVID, a lot of people are using this comment section to say if they're doing in-person, if they're doing virtual, different language capacity. Sometimes for therapeutic mentoring, right, you might have a little boy and you want him to have a male mentor. It might say like male availability or female availability. And then it tells you the last time it was updated. So if you see it's 8 and it was updated a week ago, that might not be so accurate, but this was just updated a day ago. So it's worth, like if you have a family that needs a service, it's worth reaching out to them. All of these services cover the entire state. So in doesn't matter where you live, there's always a provider that covers that area. So if you have a kid that's not necessarily in the central region, or if they're in that south central area that we don't cover, you can still search on here and it'll get you connected to the right CSA. Something I just like to warn people about. So for example, for ICC services, which is my service, when you search, everywhere you search in the state, these 2 are always going to come up. So the Learning Center for the Deaf covers any family across the state that either is deaf or hard of hearing. So they always come up. So unless you have a family that's deaf or hard of hearing, you want to look for the other option for ICC. And then again, it'll tell you if there are openings, the referral phone number, and then any other additional information. So I like to share that with people because I think the only way people are going to be able to use these services is if they know how to find them. So that website is our little cheat sheet to find resources for our families.
Yeah, I find it very user friendly. And I did share it with one of our volunteers already who had somebody out, that they know personally was interested in using it. So yeah, I think it's a great resource. Thank you.
Absolutely. So that was all I had. I don't know if anybody has questions about our services.
I do.
Yeah,
Me
absolutely.
too. And go ahead, Ed.
So this was awesome, actually. I mean, so helpful about, services or places to go, because I know so many of our advocates are so frustrated with the lack of services. But I mean, even to be able to, I think, visually see it, right, as opposed to somebody saying, no, they're on a waiting list. But
Right.
so when Peter Metz and I were first talking about this issue and he referred us to you, he mentioned to me that DCF doesn't, and I'm paraphrasing, so don't quote me, but something along the lines of that he feels like DCF does not use these services as much as they could or should. Do you have a feeling as to why that is? Now, I'm just going to give you just a tiny bit of background. So we had a mental health grant not too long ago, which was a collaboration between DCF, Family Services, and somebody else that escapes me at the moment. And we did have to fill out a referral form that had the social worker's name on there, their contact information, as well as the foster parents. And you're right, it took us a few tries to get it right, but understanding that everybody had to be on board before we sent it forward. But even then, of course, there were glitches in reaching the social workers, or getting them to respond to you. So I guess maybe it's a two-part question, but I guess the first one is just what your thoughts are. It would seem to me that it would ease DCF's burden in many, many situations.
Yeah, so we experience two types of DCF workers. We get the DCF workers who refer every single family to us, whether the kid needs it, the families are willing, they love us. Once they work with us once, they love it, because we do take on a lot of the pieces that takes some stuff off their plate. And then we get the workers that we get referrals. We try desperately to reach out to them. We'll call the area office and ask for supervisors and managers. And it's just a very difficult process to engage them. And where they're the legal guardian, it's really important for them to be aware of what we're doing for this child. So we experience both. And I'll say I have a little bit of insight into this because I briefly worked at DCF. I've been in this like realm of services for about 8 years now, and I worked at DCF for 1.5 years of that. And I will say, if I didn't have the background that I did, I would have had a much harder time being a DCF worker, because you are constantly dealing with different crises for different reasons. And there's not a lot of good training at DCF about this. The DCF workers get zero training on any of these services. So if you have a supervisor or a manager or people in your unit are not familiar to be able to share that information with you, you're like feeling blind. And if you happen to stumble across it through a case, that's how DCF workers often find out about us. And the turnover at DCF is just so high because it's a really difficult job, especially right now where, when I was there, I had 18 cases. That was a lot. They're up at like 22, 23, because we do some consultation with them. And I just can't even imagine, as a brand new person out of a bachelor's degree, having no knowledge of this scope of services, and then dealing with all these families and they just don't know. And it's really unfortunate. And we do collaborate, or at least we try to collaborate with the DCF area offices as the CSAs. But even that, it's kind of hit or miss, and you're collaborating with one person at the office. So whether that information gets shared amongst everybody or not, oftentimes it's not. But it's sad because every DCF involved family can get mass health. And that is like the gold card for mental health services for children in this state. So it's really unfortunate that more of them don't know.
Do you know Kim Ferrecchia?
Yes.
She has another, yes.
Recchia Rivas,
I will say she was helpful to us when we couldn't get social workers to respond.
Yeah.
But that was also pre-COVID, right?
Right. And Kim gets involved if a worker knows to request the mental health specialist. And again, they've got specialists for everything, but even those services are underutilized. They have a domestic violence specialist, a substance specialist. They don't use them on all the cases that they could. And again, I think they're just overburdened. They're not trained well. And it's sad because it's such a huge piece of the child serving system in Massachusetts.
Sarah, you had a question?
Yeah, I was just going to say this actually was very helpful because I'm with a family that was given CBHI services, and my question was going to be, how do you actually determine if they need them? Because in this situation, the family didn't care two hoots about getting the services. But DCF said, here, have these services. And so, you know, the therapist went in and sort of sat on the couch and observed. And of course, everyone's on their best behavior. And the therapist like, well, they don't need anything, whereas actually they do.
Right.
But if they don't, but that was good to know that the family has to buy into it. So really, there's not much point DCF offering the services unless the family buys into it. It's a waste of
Right.
everybody's time.
It's a double-edged sword, right? So DCF forces a family to engage with us. They put it on the action plan.
Right.
And then the family goes into it being forced. Like, they're not going to get anything out of it. The same way if
Right.
somebody forced me, like, oh, you need to go on a diet. I'm probably not going to lose any weight because when you're not looking, I'm going to be eating the cookies. It's the same idea. If
Right.
we're forcing families to do this, they're not going to lose the weight.
Right. Right. No, so that's actually really interesting. That helps me understand why it didn't work.
And we do try really hard to work with those families. We frame it for them of, all right, you don't want DCF in your life. What can we do to, how can we help you get them out of your life? If that's your vision, how can we do that?
Amy, you have a question?
I do. If DCF is has custody of the child or one of the children, and if there's reunification involved with one of the parents, the other parent is clearly not completing his action plan, do you still think having the mother buying in, that it would still be a good idea to refer them to you?
Absolutely. If mom's willing and DCF is willing to let us have that contact with them, when they have custody, we have to go based off of their request. So we ask them, how much contact do you want us to have with the bio parent? How much information can we share? The same way parents have to sign releases for us to talk to anybody that's not them. When DCF has legal custody, DCF signs a release for us to talk to that bio parent or to talk to that foster parent or that pre-adoptive parent, and they dictate how much contact and what that looks like. But oftentimes, if they're working towards reunification, they want as many services in place as they can get, because in their mind, it's more eyes on that parent and more people telling them if it's safe or not. So they're usually very open to that if their plan is reunification.
Thank you.
Yeah.
I mean, I guess I could see two situations for CASA in which it would work really well. And one is the one you just described, right? Which is DCF is getting ready to reunify and they need services in place. And I think, I mean, Sarah, I think we can all agree that unfortunately you got the case of cases in which everything that could go wrong goes wrong. But most families, I think, that whose kids are coming home are nervous, right? And so they would love to have some sort of help and some sort of plan in place. So that's one scenario. And I guess the other scenario that I see is early on when children are removed, when foster parents are really struggling with a child's behavior, and the bio parents may or may not be involved in that moment, but to really be able to provide those services to foster parents who also are really lost in the system of initials and, you know, ABC soup and things like that, and don't really know what to do, because as you say, just like DCF social workers aren't trained, neither are foster parents, right, to understand the ins and outs of what's available to them.
Yeah,
I see it being a
absolutely.
massive help for foster parents.
Right,
Massive help, yeah.
right.
And another common theme that we get is the kids that were adopted through DCF and the adoption was finalized 6 months to a year ago, and now they have a child that has some really significant behavioral health challenges because of significant trauma that they've endured, and DCF says, oh, the adoption is finalized, bye, have a nice life. And then this family is kind of stuck and they don't know who to reach out to and they don't know the resources. So we often get that. And DMH gets a lot of those cases as well, the Department of Mental Health.
You know, one thing I guess I thought I knew the answer to, but maybe I don't. So if a child is adopted through DCF, do they remain on Mass Health?
They do. So they
So
remain
then
on
those
Mass Health, but the case closes.
Right. So, but those adoptive parents would still be able to access your resources based on the fact that, okay,
Yep,
if
and they
know
often do.
exist.
okay.
Yeah, sometimes the parents might not know, but we try to connect with school districts and PCPs, and the CSA gets connected to all those different pieces. So hopefully, if the parents are like voicing concern to somebody in their life, at least one person will say, oh, go see this service. But I think there are plenty of kids out there that we never see, unfortunately.
Are you familiar with the Encompass program that was started recently through a grant by the Health Foundation of Central Mass?
No, I'm not. I'd love to learn more about it.
Yes, and I
yeah,
think they'd love to
absolutely.
hear from you, right?
Absolutely.
I feel like I work for them, right? I'm out there.
But they're
They-
amazing. It's a wonderful,
They're a
you're gonna
grant,
love it,
right?
Kayla.
It's a grant, right? That
Yeah.
they're really, their only job is to support foster parents. That's it. And so it's either through providing meals, right? Or trying to coordinate services for kids that are in their care, parenting coaches, trauma coaches. So
Mm,
it's a great collaboration because it's DCF, it's Jamie Karen, who's the area or the
Yep.
regional director of all the DCFs. Dr. Heather Forkey from the Faces Clinic, Diane Lanny's on there. I'm on it. There's 2 or 3 other people that escape me right now. But big organizations, and I mean, right now, so they just finished their pilot year and they're entering year 1 of their program, but they're looking for exactly these type of things
Yeah.
that they can provide as resources to their foster parents. So that was a conversation Jamie and I were having about tampons and pads when
Yeah.
you
Yeah.
joined. But when I email her about that, I will also provide her with your contact information.
I would
because
love
they're
that.
looking for training for their volunteers that are going out and visiting these foster homes. So
Yeah. And
that's
like I
wonderful.
said, I run the system of care meeting for the North Central region. So that's all different providers, DCF sometimes, DMH sometimes, DDS sometimes, PCP offices come to it, some schools come to it, and we share resources. So we have different presenters that come in month to month and tell us about what they can offer. So that
Yeah.
definitely sounds like something that would be good for our
Yeah,
area to know about.
it would be wonderful. That's
Yeah.
great.
Yeah.
Good idea. Nice. Does anyone else have any other questions? I have a few too, but I don't wanna, anyone else? You guys good? So I kind of was wondering, I liked, you talked about the brainstorming meeting where, you know, providers and like the team comes together, and I just wanted to hear a little bit more about what that looks like. And who's in, yeah, I just kind of, I'd like to attend that meeting, but first I'll
Yeah.
just hear about it. Yeah.
Yeah,
Yeah,
so
it
for
sounded
each,
nice.
it varies for each child. So when we get involved, we do that assessment and we ask families, like, who are the important people in your
Mm.
life? Who's the important people in your child's life? So we do try to always get school to the table. We try to get the PCP offices to the table.
And the
That's
CASA
difficult.
advocate, this would be a good place for a
Oh,
CASA
yeah,
advocate to
absolutely.
participate. Okay,
Absolutely. If DCF's involved, we try to get them to the table. That can always be a challenge.
yeah,
But as many people that know the child and family as possible. And we also try to bring in natural support. So maybe the aunt who has a good relationship with the child, or the grandma, or the pastor, or the
Yeah.
basketball coach, like anybody really who knows this kid. And then we review the family's vision. And then the family picks goals based on that vision. So what are the big areas that they want to work on? Maybe their vision is that the child is able to manage their emotions and not escalate for 3 hours when they're upset. So our goal is going to be that we're going to focus on their emotion regulation. And then as a team, we open it up for brainstorming. We ask the parent, all right, what do you want to accomplish between now and our meeting next month? Maybe they want the kid to learn 3 coping skills. All right, team, how are we going to get this kid to learn 3 coping skills between now and next month? And everybody on the team ideally suggests an idea or 2, and we present all of those ideas to the parent. So maybe in-home therapy is involved and they're going to teach them a skill. Maybe mom's going to watch a YouTube video with the kid on breathing and meditation. Maybe we're going to download an app on the kid's phone. The school's going to teach them a skill. But we throw all of these ideas out And then the parent gets to pick, what of these ideas do you think is going to work for you? And whatever they pick is what we work on as a team. So then we schedule our next meeting a month out. And in between, our care coordinator is reaching out to everyone. Let's say the parent said they want to do the YouTube video with the kid. The care coordinator is going to call the parent. Hey, did you do the YouTube video? How'd that work? So then in our next meeting, all right, now we learned 3 coping skills. Now what's our goal for next month to get to where we're trying to go? All right, now we want them to use a coping skill one time when they're upset. What are some ideas for how we can get that to happen? So each month we bring everybody together, we do this brainstorming process based on the goals that the parents identified, and then we work through whatever the parent wants to try. Maybe they tried the YouTube video and that was like a big failure. And so instead of the YouTube video, they're going to download an app, or the brother is going to do it with them instead, or the basketball coach is going to do it with them instead. But that's the goal of the brainstorming, is for everyone to think of an idea. It doesn't need to be that you're coming up with the idea that you're going to do. It's just an idea.
So it sounds like then the idea is presented to the child. So rarely is the child, it's kind of behind the scenes and then it's brought forth to the parent and child. It doesn't really
Right. So it
involve.
depends on the age of the child, how involved they are.
Okay.
I would
that's what I was
say
thinking.
like, 12 and older, we try to get them involved.
Nice.
You know, as we get 16, 17, they're heavily involved and they should
Yeah.
be at those team meetings.
Nice. Yeah, that's good.
And sometimes we just incorporate them at the end. Maybe they're not there for the entire meeting because they can't deal with hearing everybody talk about all the not so great stuff that's going on. So they come the last 10 minutes and hear about
Nice.
all the strengths that we're talking about.
Yeah, I love how individualized it sounds. You guys really, it sounds like you're doing a great job thinking of each family and child and not just having, which I guess that's, pretty much what that is, right? Wrap around, really
that's the goal.
individualized. I like that. Nice. And my other question was, a lot of them were answered, but my other one was, I had wondered like about families that speak, that English isn't their first language, which I know we had the website there that you showed where you can look up services, and I noticed some like Spanish speaking or different languages. But as far as your services themselves, what would that look like for families that maybe parents don't speak English or
Yeah,
whatever?
so we, being in Worcester and even in the
Yeah.
North Central region, we have lots of families that don't speak English. So we have several Spanish speaking staff, both care coordinators and family partners. We also have a family partner that speaks Portuguese. We have a family partner that speaks Twi. And then for families that we don't have their language, we don't have a staff that speaks their language, we have a wide variety of interpreter services.
Nice.
When it's sign language, if there's a need for that, we do have ASL interpreters that can come with us in person. We do often try to refer them to the Learning Center just because that's all of their staff speak sign language.
Yeah.
And it just makes it more fluid to do assessments and stuff when you speak the language.
Yeah.
But any
Nice.
other, we worked with Vietnamese, we've done a lot of Arabic families recently in the Worcester area. So
Nice.
if you've got a need, we probably can accommodate it.
Yeah.
And again,
love that.
the family would have to be open to it. I will say one of our Arabic families really struggled with the idea of an interpreter because they were concerned that it would be someone from their community that might know them. So that made them a little uncomfortable, and it took time of working with them to get them open to that. But we try if they're willing.
Yeah. Nice.
Yeah.
And actually one more. I thought that was my last one.
Okay.
I was thinking the therapeutic mentoring that you talked about, and you said they go out into the community. So first, which you covered quite a bit, is the impact that COVID has had on these services. So I was wondering what those services currently look like, and does the child, like you mentioned, maybe they're working on social skills. They go out with that therapeutic mentor and work on a certain social skill. But what if, and clearly they must have some needs or they wouldn't meet your criteria for the services, but what if like socially they're doing good, but I guess like how long does that mentoring go on and what does that look like?
Yeah, so all of the CBHI services are meant to be intensive and short term.
Right.
So ideally, these services don't continue really too far past the year mark. We can probably get to 2 years, but anything past that, insurance typically doesn't allow. But sometimes, so we close a case at 2 years, and then if 6 months later there's still a need, a new referral can be made. Technically, the next day, if there's still a need, a new referral can be made. So
Oh, okay.
oftentimes kids do end up having mentors for several years because they have one agency for a year and then that agency has to close, and then they have another agency and that
Mm.
person leaves, so they switch to somebody else. It's definitely not ideal, but it
Right.
happens.
Okay.
And then to answer your question about COVID, so as of January 1st, our insurers have put out new specifications that the default for all services should be in person unless a family specifically requests telehealth.
Hmm.
So therapeutic mentors should not just be using telehealth because that's what's convenient for them. It should be
Mhm.
based on the family saying, I want your services telehealth, which I will say for therapeutic mentoring very rarely happens.
Right.
And I started as a therapeutic mentor and can't even imagine doing that job through COVID telehealth. Like that just, I can't even wrap my mind around it because it's so opposite of what that service is intended to be.
Hmm. Thank you. Thank you very
Yeah.
much. That's all I got.
Okay.
Thank you.
This has been so helpful, and I'm so happy that we recorded it so that we can put it on the website, because I think people are going to be sad they missed it. Well, I guess they're not going to miss it, right? They can hear all of this.
Right.
Kayla, where does your funding come from? Does it come from the state?
It's insurance based. So
Okay.
we bill
That's right. You
insurance and
said
they
that.
pay
You
us.
said
Yep.
that. Yeah. Sorry. Yeah.
We
Wow.
we have done grants here and there over the years, but primarily insurance.
Okay.
Hmm. Yeah, I'm really excited about you connecting with Encompass. I think
I
that
know. I'm
is-
actually going to send them the email tonight. Tampons and therapy. Like
That's
how
right.
there's nothing
Yeah.
better, right?
That's right.
Yeah, so I will definitely do that. And Kayla, I'll follow back up with you just to let you know, or maybe I'll
Perfect.
even include you on the email so that you
Yeah.
could see, what I said and so forth. But yeah, I think that might be a great connection. Because that's really for us anyway, right? Who desperately needs it. Not that parents don't need it if there's going to be reunification, but a
Mhm.
lot of times when reunification is occurring, we're sort of on our way out.
Right.
But we certainly know many foster parents that are in desperate need of some assistance. So I really think that they would welcome it.
Yeah,
but
in my mind,
understanding that they
any
need to
child
buy-in.
that gets removed or taken into DCF custody should automatically get a therapy referral. Like
Mhm.
Yeah,
that is trauma. Every child that goes through
right,
that, having done that experience when I was a DCF worker, every child that has that happen in their life needs therapy.
That's what we
Yeah.
said. I was somewhere not too long ago. I think actually I was testifying at a hearing, and one of the, he was a representative or somebody's aide staffer, I don't know. And he said to me, how many kids in DCF care do you think have suffered trauma? I said, all of them.
Every
Oh,
Yeah.
right. I mean, all of them. I mean, just by being removed from your home, that's a
Traumatic.
traumatic experience.
Yeah.
So, well, thank you so much. And if anybody, I kind of talked a lot, so I'm sorry, but does anybody else, Nancy, do you have any questions or just
No, it was very helpful. Thank you. My family has 4 children with a grandfather, and they're having all kinds of resources already, I don't want to say thrown at them. I think in the beginning, your services to coordinate family goals would have been helpful. I think this grandfather at times is overwhelmed. He has CF, he has me, he has Compass Boston, he has a mentor for each child. He has a therapist for one, and we are close to I think we're getting off the waiting list for the others. And now they want to join sporting activities, and he's like, I can't, he's in his step trying to manage this. He has a babysitter that comes in, different people. So, but for somebody like you to sit down in the beginning and set goals and what does he really need and how can he coordinate it? It's a good problem to have though. The DCF, she's very good. She's on top of everything when I call. She's very communicative. So I just think the coordination piece would have been great, but I appreciate knowing about your services and
Mm. Thank you, Nancy. I think, Kayla, when you and I talked too, and this hasn't come up, I don't believe, this evening, is I had the question of what about children in foster care that are, or children, whether they're in foster care or not, in group homes? And if I remember correctly, Kayla, like I was wondering if you provide services, but usually they're following their own facility or their own services within the group home. So do you want to say anything about that? Just especially for those listening to the recording, that would be good.
Yeah, so we cannot work with a child that's in a residential placement. So if they go to like a CBAT or an inpatient unit and it's short term, we can work with them. Even a STAR placement, we can stay involved to kind of see what the recommendations are. If it's recommended that they go into a treatment facility versus returning to the community, then we have to close our case. But if you have a child that's discharging, let's say you've got a kid that's going to be coming home in the next 2 months, then we can get involved to try and get some services in place for them to transition home to, versus coming home and then trying to get everything in place. So if there is a discharge date, then insurance will allow us to get involved to support with that process.
Okay, nice. Thank you.
Great.
All right, thank you so
Great.
much. I'm gonna stop. Oop, where'd it go?